I do want to recognize that OJJDP has been our primary funder, and it's with gratitude that we have OJJDP here and represented, as they are the primary sponsors for the for the Blueprints effort. It's my privilege to do the initial kickoff keynote address, and I need to say in advance that that this may prove to be controversial, and that I hope, if nothing else, that it will stimulate good conversation. This is a slide, and you have these in your handout, which indicates what the knowledge base was about prevention programming, violence, drug, delinquency prevention programming, back in the 1980s. Because it's from this point that I want to talk about what progress we've made and then where we're going in the future. At least give you my indications or my ideas about where we're going. As you look at that slide, you can see that the claim was that the research community found nothing that was effective. I was careful in how I said that the research community found nothing that they could say we could demonstrate was effective. And in many respects, I think that was a failure of the research as much as it was of programs. But in any event, what we knew back in 1978 when Romig wrote this particular book was that there was nothing that we could demonstrate was effective. Since that time, we have made great progress. So today, for example, we have better theory. We have a growing number of programs which have been demonstrated to be effective. We have increasing public and government support for evidence-based programs. It is quite common now for most state legislatures and the federal government to talk about evidence-based programs and to require that programs that are applying for funding indicate that they meet some standard for being an evidence-based program. There remains a great deal of confusion, however, over the scientific standard for certifying a program as an evidence-based program. And we continue to have a fairly limited dissemination of evidence-based programs and relatively little attention to fidelity. I did a review a while back looking at the number of programs that have been evaluated in the last 10 years involving randomized control trials or good quality experimental designs. Very, very few, less than 10% of those programs made any attempt to measure fidelity as a part of that evaluation. So here's the agenda that I believe we have in front of us for the next 20 years. First, we need to establish consensus on the scientific standard for certifying programs as effective programs or evidence-based programs. We need to upgrade the quality of our program evaluations, the design and the methodology, and the reporting of those evaluations. And third, the new research frontier really has to do with the dissemination and implementation of evidence-based programs. And finally, I suggest we need to address some of the barriers to dissemination and the implementation of evidence-based programs. First, let's talk about the confusion with respect to the standard, defining what we mean when we talk about an evidence-based program. Here's a list of federal programs which provide a list of programs which they have certified as being programs which are effective programs. So there are 8 agencies there which provide such a list. The consensus across that list, I'm going to put them all up here for you. The consensus for that list involves no single program that appears on all 8 of those lists. There's only one program, LST, Life Skills Training, that appears on 7 of those 8 lists as a model or exemplary or level 1 program. That is, as a program at the top category used by that particular agency. There were 2 programs that were on 5 lists, MST and towards no drug abuse. There are 4 programs on 4 lists, Alert, Atlas, Early Risers for Success, and Functional Family Therapy, and 11 programs that are on 3 lists. The point being that even though each of these lists contains names of programs, that the standard which is being used across those lists varies a great deal. And so there's very little consensus with respect to what we mean when we say a program is an evidence-based program. The Federal Working Group, which was a group that came together involving all of the federal agencies that had some stake in violence, drug, and delinquency prevention, came together to see if they could in fact adopt a standard that those agencies might use as the basis for classifying programs. And I would just like to show you this classification and this standard, because I think it's a standard which the research community at least would buy as an acceptable standard. For all practical purposes, this standard is the blueprint standard, with the exception that randomized controlled trials are required as the evidentiary base for the certification. So the standard involves, first of all, an experimental design, a randomized controlled trial for that efficacy trial. Secondly, it requires that the effect is sustainable for at least 1 year post-intervention, and that there is at least 1 additional randomized controlled trial as an effectiveness trial. Those randomized controlled trials must adequately address threats to internal validity, and there should be no known health compromising side effects from that intervention. So there's a standard which is very similar to the blueprint standard, but actually elevates the level of evidence to the highest level, which would involve randomized controlled trials. The hierarchy of programs then that results from that classification, we can get it here. First of all, a model program which meets all of those standards. Secondly, effective programs. These are programs which lack independence between the first randomized controlled trial and the second randomized controlled trial. The scientific standard says we should have independence between the efficacy and the effectiveness trial. Many of the programs that are blueprint programs even often lack that independence. But from a pure scientific standpoint, it's important that we have independence. Third, promising programs. Now it can be a quasi-experimental design or a randomized controlled trial. It does not require any replication. Next, we have inconclusive, where we get contradictory findings or non-sustainable effects. Ineffective, which meets all standards but with no statistically significant effects. Harmful, meets all standards but with negative effects or main effects or serious side effects. And finally, insufficient evidence, which would be the classification for all others. Let's take a look then, if we were using that standard, at the list on those 8 federal lists that we looked at earlier. First of all, if we look at the Center for Mental Health Services, only 14 of the 34 programs there have actually been evaluated on this new hierarchy. So we simply don't know in that case. If we look at the National Repository for Effective Prevention Programs, incidentally, NREP no longer certifies programs. They've adopted the strategy that Larry Sherman used on the report to the U.S. Congress on what works, and they do evaluate the scientific quality of the research for specific programs and for specific outcomes, but they no longer actually certify programs. So we're looking at the NREP list as it existed in 2004 and 2005. When we look at that list, we see that 18 of the 21 programs that are listed as exemplary programs on the NREP list would qualify as evidence-based programs on the working group standard. If we look at NIDA, at their effective classification, 20 of the 21 programs have been evaluated. 10% of those would be model programs, 25% would be effective, 25% would be promising, and 40% would fall into the insufficient or inconsistent classification. The Blueprints model programs, all 11 programs have been rated. 27% of the Blueprint programs would be model programs, 64% would be promising programs. None would be below the promising level. If we look at OJJDP, at the Title V site, we've looked at 33 of the 40 have been evaluated or rated on the federal hierarchy. 9% of those would be model programs, 30% would be classified as effective, 15% as promising, 45% as inconclusive or insufficient evidence. The Office of Safe and Drug-Free Schools from the Department of Education, 11% would be classified as model, 25% or 23% is effective, 35% is promising, the rest ineffective or inconclusive. The Hayes site, 12 of the 12 programs on that site have been rated. 25% would qualify as model, 30% is effective, and the rest would be insufficient evidence or inconclusive. The point being that the standard that we're talking about here is one which is a high standard and one which I think would allow us to make a very clear definition of what we mean by evidence-based programs. So this is a definition that I propose, that we use as the definition programs that would be classified as model, effective, or promising on the federal hierarchy, or those which have proved to be consistently positive in the meta-analyses. And only model programs, those programs that meet that highest standard with 2 randomized controlled trials, evidence of sustainability for at least 1 year, no negative side effects as the standard for model programs. And only model programs should ever be taken to scale. So if we used a recommended set of lists using that definition, what we get is that all of the Blueprint programs would qualify as evidence-based programs. 60% of the NIDA programs, if I'm reading here from the side, sorry, would be effective. The OJJDP Title V, it looks like 54%. The Office of Safe and Drug-Free Schools would be 67%. The Hayes site, Level 1, 58%. So if we use that standard and then use the top classification from those federal sites, we would, for the most part, be getting evidence-based programs based upon this definition. Let's turn then to the issue of the evaluation design and methodology issues. First, it's my view that we need to establish consensus on the definition of replication. The Blueprints Advisory Board is struggling over this particular question because it's often the case that when a designer does the initial evaluation and they get ready to do a second or third generation clinical trial, they always change the program, either the modules in the program, the population to which the program is now being used. So there are changes in the program itself. And if we have replication as a standard for certifying a program as an effective program, then the issue is how do we establish what the replication is? It is my view that it would be possible in most cases to actually embed a true replication into that second or third generation trial. Still add new modules, still apply that program to new populations, but embed within that new clinical trial a replication so that those of us on the blueprint board, for example, could look and say, this is a replication. This now qualifies the program for being a model program because we have a replication that works. Third, we need to encourage all of the research which is ongoing to address the question of fidelity. No program, no matter how good that program is in its clinical trials, is going to be effective if it's not implemented with fidelity. So we need to measure the level of fidelity when we are implementing programs. And this is not typically a difficult thing to do, but it in fact is rarely done. Then we need to pay better attention to threats to internal validity, and we need to consider the external validity question. It is the case that in most cases, the number of clinical trials that we have, even for our best blueprint programs, are in fact fairly limited. And yet the generalizability of those programs we're quick to make into new settings and new environments. I think it's time for us to begin to consider that external validity issue and address the question, to what extent can we generalize these programs into various populations in various regions and communities and situations? It's an important issue. It's also the case that the threats to internal validity are often ignored in the evaluations that we review. Issues having to do with attrition, issues having to do with following ends across different evaluations so that we can determine whether cases have been lost or not lost. Issues with respect to the reliability and validity of the measurements which are used. So there are a whole set of internal validity issues which we need to more consistently address as we do our evaluations. It's also the case that we need to address how we report our findings. First of all, I would like to recommend that all of our randomized controlled trials be registered following the International Committee on Medical Journal Editors recommendations for clinical trial registration. Secondly, I think we need to remember that non-significant negative findings from our research and from our trials are as important a finding as positive outcomes. What doesn't work is as important to know as to demonstrate what does work. So we need to develop guidelines for what specific issues need to be addressed whenever an evaluation is written up, so that there are a set of standards for the write-up of our evaluations. Finally, that there are recurring problems which involve adequate descriptions of the design, tracking ends across waves and analyses, attrition, estimates of effect sizes. Statistical significance by itself is not enough, and other threats to internal validity. The next issue has to do with the new research frontier, and that new research frontier has to do with dissemination and implementation of evidence-based programs and practices. This is a quote from the National Implementation Research Network in 2007. Very little is known about the processes required to effectively implement evidence-based programs on a national scale. Research to support the implementation activities that are being used is even scarcer. So I would like to present a few of the findings from the Blueprints Prevention Replication funded by the Office of Juvenile Justice and Delinquency Prevention to at least describe what I think are the important issues in this whole area of implementation and dissemination. program implementation involves the following elements: the program dissemination, program fit, site preparation, training, technical assistance, program fidelity and adaptation, predictors of program quality, and program sustainability. So let's look at a few of those briefly. First of all, program dissemination capability. What we mean when we talk about a program being ready to disseminate its program and having a good dissemination capability means that there are published materials, handbooks, curriculum, and manuals which are ready and prepared to distribute. That there is a means for certifying trainers to deliver that intervention. That you have a high-quality packaged technical assistance capability to go with the delivery of that program. That there are process evaluation measures, scales in place to help that agency or community implementing the program to assess the fidelity of that program. And finally, a dissemination organization dedicated to marketing and delivery, and a data management system that's in place. Programs that are really ready to be disseminated and taken to scale will have all of those capabilities in place. When we did the first implementation of the Blueprint programs, we were funded to implement each of those 10 programs in 10 sites. And the fact of the matter was that there were only 3 or 4 of the Blueprint programs at that point that had this kind of dissemination capability. We spent the first year or so helping programs to develop the dissemination capability because they simply didn't have it. I'm happy to say that at this point, virtually all of those Blueprint programs have that capability, but there are still many programs out there, programs on federal lists as programs that are evidence-based programs that do not have that capability. The Federal Working Group standard has a separate standard for rating the dissemination capability. The NREP standard also looks at dissemination capability as one of the criteria. Program fit. This is an important issue. The question here has to do with whether the program addresses the needs and the existing barriers to learning in that community or that school. Does it address the risk and protective factors that are targeted for change? At the last, I guess it was not the last meeting of the Office of Safe and Drug-Free School in Washington, but the meeting before that, there was one of the sessions had to do with presenting evidence-based programs. And it was interesting to me that the first 3 questions from the floor at that meeting had to do with how do we use what are on these federal lists. And there was this assumption that you had to take the top program on the list. Or how do we evaluate whether this is a program which we ought to be implementing or not implementing? This is the critical question for the practitioner. Does this program fit? Does it address the risk factors or the protective factors that we are targeting for change in this school or in this community? And that question of fit is critical. It also involves asking the question of whether the program has been certified for this type of a population. Because it remains true that some programs, which are evidence-based programs, have only been certified for white middle-class populations and not necessarily for other populations. So this is an issue of fit that must be addressed. Third, what's the level of certification that this program has? What do we know about the evidence for this program? And you should always take the program which has the highest level of certification that fits your particular community or school's needs. Next, we look at site preparation. Most failures occur here. Most failures take place because the site is simply not prepared to actually implement a program. The critical elements in being able to implement a program in a community involves having a local champion, having administrative support, having organizational stability, and community credibility and routinization potential. One of the biggest problems we had when we were implementing programs in schools, we were putting LST, for example, into over 400 schools across the country, had to do with the instability of the administration in schools. Teacher turnover, principal turnover, the stability of the organization is a critical factor in being able to have a successful implementation. And finally, developing clear expectations and contracts ahead of time before the implementation actually begins. Next, we look at training. In the interest of time, you can read that. I'm going to skip on to technical assistance, having a technical assistance capability. One of the things we learned had to do with the fact that the quality of technical assistance delivered to these blueprint programs tended to decline over time. So there is a warning that we need to be careful that we sustain a high level of technical assistance with the delivery of these programs. There was a lack of proactive delivery. That is, there was a tendency for the program, the people delivering the program, to sit back and wait for the school or the community to call and say, we're having a problem. In the best case scenario, the technical assistance providers were calling and regularly, proactively asking how things were going, whether there were problems. The difficulty is, by the time sometimes that the people implementing the program realize they have a problem, the difficulties in setting that straight now become very, very great. Whereas if we had a more proactive delivery of technical assistance, we could avoid that. School-based programs appeared to be delivered best. Family-based programs had the most consistent and proactive delivery of technical assistance, and variation in perceived need by program type. That is, there were certain kinds of programs where the perceived need was low, and there were other types of programs where the perceived need is high. Those people delivering technical assistance need to know if they're delivering a type of program where there's a high need for the delivery of technical assistance. Fidelity components. We looked at adherence to the intervention as it was designed, exposure, the quality of program delivery, and participant responsiveness. With respect to adherence, we achieved a fairly high level of fidelity with respect to the program modules that should have been delivered. For the blueprint programs, the violence programs, our levels of fidelity were 86 to 100%. In the case of LST, our fidelity levels were 81 to 86%. We did not do nearly as well in that implementation with respect to the exposure and dosage forms of fidelity. You can see that on the school-based blueprint prevention programs, the dosage levels were only 33 to 50% of what was required in the design of that program. With LST, they were a little better, 56 to 78%. One of the big issues in the dissemination and implementation has to do with what's called the fidelity versus adaptation controversy. And that is an argument that in order to get fidelity or to get communities and schools and agencies to implement the programs, you have to give to them the ability to make local adaptations. There is a great pressure for that. We experience that. If you've been involved in implementing programs, you know that there is this sense in most local communities, local schools, that we know our kids best, we know what the problems are, and we need to have the freedom to adapt the program. So that adaptation threatens fidelity. And so there is this question of how do we achieve some balance. First, I would like to say to you that in my own experience, at least in our experience in implementing blueprint programs, that the need for local adaptation is greatly overestimated. It turns out that we were, in some people's minds, Nazi-like in the way that we insisted that programs be implemented the way that they were designed. The good news is that after the fact, we often were complimented for doing that once they saw how the program worked and how effective that program was. But there were great threats initially with respect to that validity. Adaptations, if they are to be made, must be consistent with the theoretical rationale for that program. And one of the big concerns for me was that very often the adaptations that were proposed were in conflict with or inconsistent with the understanding of what mechanisms were operating to produce the change that we know that this program can produce. So unless those people who are suggesting adaptations have a good understanding of what the theoretical rationale is, then they don't understand how an adaptation might actually be iatrogenic and harmful to the program. Language and cultural adaptations are the ones which are most easily justified. However, an increasingly large body of research is indicating that there is little evidence for significant racial, ethnic, gender, or class differences in good evidence-based programs. There are exceptions, and I believe we always have to test for that. But the fact of the matter is, most of the evidence-based programs that we're talking about, most blueprint programs, have been proved to be effective across racial and ethnic, gender, and class differences or populations. That's very good news, because it suggests that the programs are not particularly sensitive and that the developmental processes that our young people go through are largely similar for those from those different populations. And finally, the most frequent threats to fidelity did not take place at the point of the negotiating between the program deliverers and the implementers, where you would expect it to take place. Most of the threats to fidelity took place with line deliverers, with teachers in the classroom who didn't like the LST dating component and substituted for that a high-risk consequences or what's the term? A program which talks about how negative the effects of that program would be. Scare tactics, in essence. And what we know about scare tactics in general is that they're not effective. So the fidelity implementation issue. Sorry, let me catch up with my slides here. The fidelity adaptation issue is one which we have to recognize. The adaptation side is likely to reduce effects, is as likely to reduce effects as to enhance them. That local adaptation may increase buyout, but it also creates uncertainty about program effects, and a program success must be judged by real changes in behavior, not the number of adaptations or survival. DARE, at one point, was in 80% of our elementary schools in this country, but it was not an effective program. So we can't judge the effectiveness of a program by that issue. The survival question, it may be true that local adaptation allows for greater survival. But if what is surviving is not an effective program, what have we achieved? So the issue has to do with effectiveness first. And we had a fairly high rate of success in this particular initiative in programs that delivered programs with fidelity, were also successful in completing those programs and sustaining those programs post-funding. And I don't remember the exact percent, but it was a fairly high percent the last time that we checked. Okay, finally, we want to look at the issue of overcoming the barriers to implementing effective evidence-based programs. The question is, why are we not implementing evidence-based programs? First, I think that it's hard to sell prevention. The focus typically is on improving our responses to violence. I remember the summer after the Columbine incident here in Colorado, we had a summer program on violence prevention that was a direct result of the Columbine incident sponsored by the governor and the attorney general. And if you looked at that agenda and what was covered, 80 to 85% of the issues had to do with police response and victim assistance to that particular emergency. And I think that's very typical. In all of the school shootings, if you see what happens and what people talk about, for the most part, they talk about the response to the violence rather than looking at the prevention. It's hard to sell prevention. It's hard to sell it to legislators when it's going to take 4, 5, 6 years before the program is actually paying for itself, and their term of office is 2 years or 4 years. It's hard to sell. The programs are not necessarily addressing the strongest risk and protective factors. This is another problem, I think, why it's hard to sell the programs. Third, there's confusion about the standard for evidence-based programs. What do we mean by that? And there is so much confusion around that it's interfering with our ability to sell evidence-based programs. Finally, politics and parochial judgment often trump research. It's amazing to me, but when we look at school-based drug prevention programs, for example, we still see the old boy and old girls networks operating with respect to the selection of programs. Looking at evidence still is not the norm. The norm is to go to a conference, look at the publicity given, the slick brochures by the agency selling programs, and to make a decision based primarily upon that and who you know and who's got a connection with somebody in the school district. We really need to get past that kind of selection process. And then there is finally increasing professional resistance to evidence-based programming and implementation, and a failure to implement with fidelity. I was surprised to see a number of cases where professionals are now questioning the usefulness of evidence-based programs. Here's one quote, for example. I particularly enjoyed your most recent article warning about the potential tyranny of evidence-based practices. I think you underplayed the possibility that an emphasis upon such programs can inadvertently undermine rather than enhance school-wide reform efforts. There is virtually no evidence that evidence-based practices contribute to overall school effectiveness, as data on such an issue are never gathered. And this was from a well-respected research scientist. This is the NREP answer to the question of what is evidence-based, and in their particular case, they are essentially arguing that you need to balance the local practitioner's understanding of need with the research for an evidence-based program. Here's another quote. This is from a book published by the Center for Mental Health in Schools at UCLA. There is little evidence for the success of most prevention programs. That part's true. Those programs shown to be successful return very small effects of a very limited scope. It is true that in general the effects may be small, but if we look at those evidence-based programs, those effects are in fact quite large. The impact of unsafe schools on health and academic performance, I thought I would just address that question that the first critic mentioned, that these kinds of programs don't have a general effect on the overall well-being of students in our schools, and yet this is what the research shows with respect to the effect of unsafe schools on health and academic performance. Poorer student health, higher rates of dropout, lower test scores, smaller gains in academic performance over time. I think the evidence is fairly clear that if we can improve the social climate of our school and make it safer with less drug use, less violence, and less delinquency, we do have a significant impact on the overall effects on students' health and well-being and academic performance in the school. This is a survey that was done of schools which looked at the programs they were implementing. Over 2/3 of schools reported the use of at least one substance abuse program. Almost half reported using 3 substance abuse programs. But only 1 in 4, approximately 1 in 4 schools were implementing an effective research-based, evidence-based program. And in general, the quality of the implementation of those programs was quite low. So the overall estimate was that somewhere between 10 and 15% of our schools were implementing evidence-based programs with some minimum level of fidelity. We still have a serious problem with respect to dissemination. Finally, just to give you a feasibility example, it would cost approximately $550 million to put LST into every middle school in the United States. We're currently spending an amount which is $40 billion per year, so that to put LST in every middle school would cost 1.5% of what we're currently spending on drug control. It seems staggering to me that we are not implementing this program or other effective drug prevention programs, which could be done for a fraction of the costs that we're currently spending. All right, conclusions. We need a uniform scientific standard for certifying evidence-based programs. Existing federal lists provide some guidance, but programs other than those in the top category are almost always problematic. Evidence-based programs should be selected for its known effect on particular risk and protective factors for specific populations or groups. If you decide to use a program that's not certified as evidence-based, ethically, you must evaluate that program, because the risk is, and we know that we have programs that we are implementing today here in the state of Colorado, and I bet in your state, that we know are harmful. It's a matter of time before we're going to see a class action suit in this country for court ordering children into programs that we know are harmful. So if we are not using an evidence-based program, we have a moral obligation, an ethical obligation to evaluate that program to determine whether that program is effective or not. And finally, we should not be using any program that the evidence suggests is harmful. Okay. There may be issues you have with me on some of that. That's fine. I'd love to talk with you about those. I hope that it will stimulate our conversation throughout the day. And I wish you the very best as we go through this day. I hope you have an opportunity to learn as much as you had hoped that you would learn at this conference. And you're dismissed now to go to your breakout sessions. Thank you.